Hello, everyone, and thank you for joining us. My name is Suzanne LeBlanc, and I'm a neuroradiologist and the Director of Clinical Relationships at the Focused Ultrasound Foundation. During April, which is Parkinson's Disease Awareness Month, I am proud to present this webinar entitled New Approaches for Parkinson's Disease Treatment. Now, every 6 minutes, a new person receives a diagnosis of Parkinson's disease in the United States, which adds up to 90,000 patients every year. And even during this 1-hour webinar, 10 patients will hear this diagnosis. Although there are numerous medications to help treat various symptoms related to Parkinson's disease, many patients do not respond well to them or develop other serious side effects. For treatment-resistant patients, there's a surgical procedure that places electrodes in the brain, but this is invasive and requires close follow-up and continued maintenance. Now, patients that do not respond to medical therapy and do not choose surgery have an option to be treated with focused ultrasound, an incisionless procedure. Now, Parkinson's disease and other neurodegenerative diseases are a strategic focus for the Focused Ultrasound Foundation, and we are dedicated to improving the lives of patients suffering from these diseases. We launched a $10 million campaign in 2022 to support innovative research for Parkinson's and other neurodegenerative conditions, knowing that this pipeline of important projects will continue to accelerate clinical adoption. We played a critical role in accelerating the FDA approval of focused ultrasound to treat Parkinson's, and we are now funding a pipeline of more than 20 active clinical trials. Our strong relationship with partners like the Michael J. Fox Foundation allows us to leverage our donors' giving. Now, today we've created a very special program for you to learn more about Parkinson's disease. You will hear from 3 experts that will share their knowledge about typical symptoms and conventional treatment options, focused ultrasound and how it's used to treat patients, and the current landscape for reimbursement. After these presentations, stay tuned because we have a very special surprise. You will hear directly from a Parkinson's disease patient that had focused ultrasound, and his story will give you a truly unique perspective. Finally, we will have a Q&A session so you can submit your questions or thoughts through the Q&A function at the bottom of your screen for any of the panelists. Now, please allow me to introduce our first speaker. Dr. Rebecca Gilbert is a physician scientist and the Vice President and Chief Scientific Officer of the American Parkinson's Disease Association. Dr. Gilbert received her medical degree at the Weill Medical College of Cornell University and a PhD in cell biology and genetics, also at the Weill Graduate School of Medical Sciences. She then completed her neurology residency training as well as movement disorders fellowship training at Columbia Presbyterian Medical Center. Prior to joining the APDA, she was an associate professor of neurology at the Fresco Institute for Parkinson's and Movement Disorders, NYU Langone Medical Center, initiated and directed the NYU Movement Disorders Fellowship, and participated in clinical trials and other research initiatives for Parkinson's disease. We are truly lucky to have her today. And Dr. Gilbert, the floor is yours.
Thank you so much for that introduction. And I am very, very happy to be here today to talk about Parkinson's disease in general and how the Parkinson's disease treatment landscape is embracing focused ultrasound as a treatment option as well. So I am going to share my screen and start my presentation. We are going to discuss available treatments for Parkinson's disease and where does focused ultrasound fit in. And I advance to my second slide. Let me know if you can't see it. So I'll start by talking about the general symptoms of Parkinson's disease and the general treatments that are available, and then move on to when the general treatments of Parkinson's disease no longer are working as well as they should, and what advanced treatments are available. So here we have a slide of the symptoms of Parkinson's disease. At the top of the slide is an accounting of the motor symptoms of Parkinson's disease. And those are tremor, stiffness, slowness, and problems with balance. These motor symptoms are visual. Another person can see them. A person can look at a person across the room and say, oh, that person has Parkinson's disease. I see they have a tremor. These symptoms are due to a lack of a brain chemical called dopamine. But as this depicts, there is an entire world of symptoms of Parkinson's disease that are not related to movement, and those are called non-motor symptoms. And they're typically related to the lack of other brain chemicals that are not dopamine. There are many, many symptoms included in this non-motor category, and they include mood disorders, sleep disorders, problems with blood pressure, problems with the gastrointestinal tract, problems with smell, problems with pain. It's a very, very long list of potential symptoms. Some people have one of them, some people have two of them, some people have more. There's a lot of variability in the non-motor symptoms. Focused ultrasound and various other treatments that I'm going to be discussing today are focused primarily on the motor symptoms, on the symptoms that involve movement. And so this whole other world of non-motor symptoms we're not going to be discussing today, but I do want to mention them because they're very important in terms of how Parkinson's disease is treated in general. But today we're going to focus on the motor symptoms, the ones that are due to a loss of the brain chemical dopamine. So what are the available treatments for the motor symptoms of Parkinson's disease? They fall into three main categories. We have medications, we have therapy and exercise, and then we have advanced, more involved treatments, and there are three of those available. One is called Duopa, and one is called deep brain stimulation, and one is called focused ultrasound. So I want to spend a moment on this slide discussing exercise and physical therapy and occupational therapy, speech therapy. Those are incredibly important treatment options for Parkinson's disease. I want to put that out there for anyone listening. And so, we tend to talk a lot about medications, we talk a lot about procedures, but this other element, this element that involves making sure the body's in motion, is extremely, extremely important. And really nothing can happen without that piece. And so if you are a person with Parkinson's and you're not engaged in exercise and you're not getting physical therapy or other therapies that may help you, please talk to your doctor to include that as one of the treatment options for you. So now we'll talk about the medications for the motor symptoms of Parkinson's disease. And my next three slides basically list all the FDA-approved medications for Parkinson's. This is not meant for you to memorize. It's just meant to give you a general overview of how many medications that are available. And in fact, in the last 5 years, there have been 5 new medications that have been approved. In the past 10 years, there have been more. There have been probably about 10 medications approved. So there's really been quite a significant movement in getting these medications out into the hands of people with Parkinson's disease. Again, all these medications that have been approved in the last 10 years are focused on helping the movement symptoms of Parkinson's disease. I'll qualify that. There have actually been a couple that have been focused on specific non-motor symptoms as well. But these charts focus on the motor symptoms of Parkinson's disease, and they really all these medications that help the motor symptoms of Parkinson's somehow manipulate the dopamine system. They're either dopamine itself, or they're a medication that mimics dopamine in the brain, or they're a medication that decreases the breakdown of dopamine. They in some way help the dopamine system to be more robust in the brain. And so we start with the dopamine precursors, the COMT inhibitors, dopamine agonists, and other medications. And they're all medications that are available and medications that you can talk with your doctor about for your own symptom control. So when are medications not enough? So we have to discuss this clinical concept called motor fluctuations. Motor fluctuations refers to a clinical situation in which the medications that are given for Parkinson's do not work evenly throughout the day. So if you look at the left part of the slide, we have a clock, a 12-hour clock, and a person on this 12-hour clock is meant to take their medication at 12 o'clock, 4 o'clock, and 8 o'clock. In the beginning of taking this medication, when they're first diagnosed, a person takes their medication and they're in the green the entire time. Their symptoms are well controlled, their dopamine levels are even, and they don't really realize that their medication is changing in any way. They take their medicine, they take their next dose, everything is great. As the disease progresses, however, this stops being the case for many people. So a dose may be expected at 12, but the person doesn't really get that nice on time, or the medication doesn't work right away, and they have maybe a half an hour, 45 minutes where they're waiting for the medication to work. Oh, then the medication starts working and they're in the green for a little bit of time, but that period of time may not be a nice 4 hours. It may be 3 hours, it may be 2.5 hours. And then slowly they start to feel that the medication is no longer working as well, and they go into the red. And then by the time they're meant to take their next medication, they're really not functioning well and their symptoms have returned. And throughout the day, they're going from green to red, from green to red, up and down and up and down. This is a phenomenon called on and off time or motor fluctuations, and it can be very, very, very tricky. Now, there are many medication adjustments that can help with this problem. You can take medications more frequently. You can add another medication on to lengthen a dose of medication so that it lasts longer. There are many, many different medication manipulations that can occur that a doctor can prescribe in order to get back to that nice green clock. However, sometimes those manipulations, no matter how many you do, you change medication a little bit back and forth, and you're not getting that nice, even dopamine distribution anymore. Sometimes what happens is that the green parts of the clock are not predictable. So the way this depiction is drawn, it's nice and predictable. You take your dose at 12, you turn on a half an hour later, it lasts 2 hours, then you turn off. So that may be reasonable because you know in the day when your 2 hours are going to be. But sometimes those 2 hours are unpredictable. So you take your dose and sometimes it takes a half an hour for the dose to work. Sometimes it takes an hour. Sometimes it doesn't work at all. And then once it starts working, you may get 2 hours, you may get 3 hours, you may get 1 hour, and then you're back to needing another dose. So you can't rely on your good time. You can't rely on the fact that you'll have a particular time of day where you can get your work done. And so there's this unpredictability of your day as well. And that, of course, can lead to very significant decreases in quality of life. Another problem that happens with medications is that the medication may cause extra movements. So when we had depicted here in green and a person's symptoms are under control, they may be too well controlled, and a person has what's called dyskinesias or extra movements. And so you're not just fluctuating from not moving well to moving well, you're fluctuating from not moving well to moving too much, and then not moving well, then to moving too much. And so this on and off phenomenon with dyskinesias is a problem as Parkinson's advances for many people. So when to consider an advanced treatment? It's when the medication response is not reliable and fluctuates, when dyskinesias can become problematic. So I should mention that these extra movements may be mild and may not be a problem for people at all. They may not even notice them, but they may be very problematic and affect balance, can cause falls, can be socially embarrassing for some if they're very significant. And the other time to consider advanced treatment is when the tremor is not responsive enough to medication, because tremor may not respond as well as some of the other symptoms and is well treated with some of these advanced treatments. So the standard advanced treatment for the last 20 years, approved in 1997, is a treatment called deep brain stimulation. This is a surgical procedure where electrodes are placed deep within the brain and they deliver electrical impulses to deep brain structures. And by these electrical impulses, they disrupt the abnormal circuitry of Parkinson's and thereby normalizing movement. And deep brain stimulation is effective for the symptoms that dopamine treats. So a deep brain stimulation surgeon will inquire, how good is your on time? How good is the time that you get when your medications are working really well? That's what you can expect from deep brain stimulation, that you'll get that type of response, but without the ups and downs that the medication can contribute to. So these electrodes that are in the brain, they get tunneled out from under the brain, under the skin, so no one can see it, and then attached to a battery pack at the chest called an IPG, or an implantable pulse generator. And this generator can be programmed to deliver electrical stimulation to the brain. The new kid on the block, not so new anymore, is focused ultrasound. And focused ultrasound, you can see this depiction here, a person is their brain is contained in this sort of hat-like structure, and ultrasound waves are delivered from the various parts of this helmet into the brain. And where the ultrasound waves converge from the different parts of this helmet, where they converge in the brain, there is enough heat that forms a small lesion inside the brain. And this small lesion also interferes with brain circuitry, the abnormal brain circuitry of Parkinson's, thereby normalizing movement. And so this is another way of interfering with the abnormal Parkinson's circuitry by creating a lesion without cutting open the brain and creating a lesion with a surgical procedure. Now, this focused ultrasound was approved for tremor control in Parkinson's in 2018, and then in 2021, approved for some of the other symptoms of Parkinson's, including slowness, stiffness, and the extra movements of Parkinson's that can occur from the medications, as I discussed before. And so many people out there probably listening are confused. So there's this deep brain stimulation surgery that's available, and then there's this focused ultrasound surgery. How do I choose between the two? And so here's a chart that we'll go through quickly to try to give some of the basic differences between the two procedures. And again, this is a personal decision. This is a decision that needs to be made with information from your neurologist, from the neurosurgeon that is going to be consulting with you. And we'll hear more about this from other panelists today to try to give you a sense of how do you know whether focused ultrasound is the way to go versus deep brain stimulation? So the first is sort of the definition of what focused ultrasound is. It's an incisionless ablative surgery. So there are no cuts in the skin, yet you create a lesion in the brain, as I discussed with the focused ultrasound helmet. It's an outpatient procedure. Deep brain stimulation is an implantable system, so you actually leave the hospital with wires in your brain and a battery pack. So that's one difference. There's no equipment that is left in your body in focused ultrasound. Focused ultrasound creates a permanent lesion in your brain, and that's the point, is that lesion is going to disrupt the abnormal circuitry. In deep brain stimulation, there's no lesion. You have the electrode sending signals to the brain to disrupt the circuitry. Focused ultrasound is used primarily unilaterally on one side of the body for bradykinesia or slowness, rigidity or stiffness, and tremor. And it's used bilaterally only for tremor. In deep brain stimulation, it's used on both sides of the brain for Parkinson symptoms, slowness and stiffness as well. Now, this may change, and this is something that we may discuss further, but currently that's typically the practice in many practices. Focused ultrasound, this is a really important one. Focused ultrasound may have less risk for people that have pre-existing cognition problems. There is a concern that deep brain stimulation may worsen cognition in somebody who has a pre-existing cognitive problem. And so typically, before deep brain stimulation is done, a person gets neuropsychiatric testing. So a full battery of testing of their cognition to make sure that they are in the normal range before the deep brain stimulation. Somebody who does not have normal cognition is typically not a great DBS candidate, but may be a candidate for focused ultrasound. Focused ultrasound may have some potential long-term mild side effects because of the fact that it's a permanent brain lesion. For deep brain stimulation, these side effects are generally stimulation-induced. They're due to the fact that the electricity is being directed from the electrode into the brain. And by changing the stimulation, and there's a lot of potential to manipulate how the stimulation is given, those side effects can be reversible. So there can be an ongoing process of manipulating how the stimulation is done to try to maximize benefit and decrease side effects. Focused ultrasound, there's no manipulation. You have the procedure and that's the effects that you expect. On the flip side of that is that focused ultrasound does not require long-term maintenance because it's one and done. DBS, however, does require the maintenance and that manipulation. So the good part of the manipulation is you can change things as things evolve and you can try to reduce side effects. The downside is that you're going back to the doctor to get these manipulations. And finally, deep brain stimulation is a more complex surgery involved, and so patients tend to want to have patients that are medically stable and don't necessarily have a lot of other medical problems. Focused ultrasound can be considered in the more medically complex patients. So that's a general overview of focused ultrasound versus DBS. Both good options, and both need to be considered in the context of a particular person. So on that note, I'm going to say thank you so much for inviting me and for allowing me to give this overview. And I will turn the mic back over to Dr. LeBlanc.
Oh my gosh, thank you, Dr. Gilbert, for giving that great presentation. You clearly made that complex topic really easy to understand. And you provided the perfect segue for our next speaker. So thank you very much. I'd like to introduce Dr. Paul Fishman. He's a clinical professor of neurology, adjunct professor of pharmacology and neurobiology at the University of Maryland School of Medicine. With dual training in neuroscience and neurology, his main research interest is the translation of novel therapies for neurodegenerative diseases such as Parkinson's disease, Alzheimer's disease, and ALS. He is the co-founder of the Joint Neurology Neurosurgery Deep Brain Stimulation Program at Maryland for the treatment of movement disorders, and is the intraoperative neurologist leading the group that programs the devices, so he knows a lot about that. His recent research interest involves therapeutic use of focused ultrasound in the brain, and he's a member of the FUS Center of Excellence at Maryland and is the neurology arm of the team instrumental to the first FDA approval of this technology in the brain for the treatment of essential tremor. Current studies with patients with Parkinson's disease explore this technology as a less invasive alternative to DBS. And with collaborations in radiology and pharmacology, they're combining focused ultrasound with some magnetic attraction to enhance minimally invasive stem cell deliveries to the brain. So he clearly knows a lot about this topic. We're lucky to have him. And Dr. Fishman, the floor is yours now.
Well, thank you, Suzanne, for the invitation, and thanks to Dr. Gilbert for a wonderful introduction about Parkinson's treatment. I'm going to talk a little bit about both the present and hopefully the future of focused ultrasound for Parkinson's disease. And as Dr. Gilbert mentioned, the current use and FDA-approved use of focused ultrasound is to really do a form of brain surgery. We use high-intensity focused ultrasound, and the goal is to converge all the sound energy from those 1,000 emitters in these devices on a very specific target and destroy it, and hopefully get long-lasting to permanent relief of symptoms. And MRI can not only give you wonderful images of brain, but MRI can actually measure brain temperature. So as opposed to the old days, and surgery for Parkinson's has been around since the 1950s and 1960s, we can very specifically target a brain area and gradually heat it and destroy it. And what it has in common with deep brain stimulation is the majority of DBS cases are done awake, particularly for the placement of the brain electrodes. Almost all focused ultrasound for Parkinson's and related conditions is done awake. The patient is part of the surgical team, and patients are interviewed during the process and examined during the process, because as we raise up temperature, if normal is about 37 degrees centigrade, as you get up to about 47 with gradual amounts of energy, you will find that for a short period of time, patients, if you're on target, patients' symptoms like tremor and slowness and stiffness will get better. And we check the patient, we examine them, have them out of the MRI, but still in that same head frame that we use for DBS. We make sure that no side effects are occurring from injury to brain and neighboring brain areas. And if that's the case, we go on and try to make a permanent lesion with higher intensity. And again, the awake patient is part of the team. As I mentioned, surgery for Parkinson's disease, in a lot of ways, it doesn't seem to make sense. In general, it's not a great idea to have part of your brain coagulated and destroyed, but in very specific situations, and those include Parkinson's disease, and actually they include epilepsy as well, where there are overactive portions of the brain. Destroying that small portion can actually relieve symptoms. So the initial area, you went in, you put a physical probe in, you coagulated it, and sometimes you got unexpected side effects, particularly when treating both sides of the brain. These were irreversible procedures. And in the old days, and this is before MRI, before these very accurate frames, complications were not uncommon. In the late 1990s, as Dr. Gilbert mentioned, this type of surgery was replaced by deep brain stimulation, where you basically jam brain activity, you interfere with it. There's no intent to make a brain, there's no need to make a brain injury, but the fact that you're putting a physical probe deep within brain, all forms of surgery have the potential complication of bleeding or infection. And one of the most serious places you can have bleeding or infection is in the brain. And so now we've kind of, in some ways, a step back and a step forward. A step back where this is not a jamming signal. This goes back to coagulating a spot of brain, but it's done without a physical probe. And that's what dramatically reduces the risk of bleeding or infection. As Dr. Gilbert mentioned, the motor symptoms of Parkinson's, tremor, slowness, stiffness, are due to the loss of the dopamine-containing cells in one particular brain area. When those cells are lost, other brain areas become overactive, and they're the targets for both deep brain stimulation and for focused ultrasound. And the different targets treat different symptoms of Parkinson's, and they actually, separate studies are done, and there are separate FDA approvals for these locations. For tremor that doesn't respond to medication, the target that's used is the thalamus. For the commonest target for deep brain stimulation, where again, these dose fluctuations, or sometimes patients or medications don't kick in and they're off, and other times they seem to be overly sensitive to the medication and they develop these abnormal movements or dyskinesias. That commonest place is a very small brain area called the subthalamic nucleus. And for areas where particularly patients have these abnormal involuntary movements due to levodopa, the target called the globus pallidus, or GPI, has always been the recommended target for many years. You're going to hear a bit about insurance coverage later, but as we all sadly know, all parts of the government don't all work together in synchrony. And so even though insurance coverage is limited or spotty across the United States, for patients with Parkinsonian tremor, it actually has been FDA approved since 2018. And tremor reduction is close to that of DBS. It's about 2/3, about 65%. And as Dr. Gilbert mentioned, the side effects are mostly mild and mostly short-lived. There certainly, it is a permanent brain lesion, we hope, for the point of view of effectiveness, but there can be long-lasting side effects. It is not without side effects. For patients with dose fluctuations, and particularly dyskinesias, it was FDA approved from a large study that gave it FDA approval in 2021. And these are for patients, some of them had the abnormal movements, dyskinesias, some of them had off, many of them had both. And so as a group, most of them got meaningful, noticeable improvement. And this type of study, we even did, it's not sham surgery, but many of the patients underwent a sham procedure where they actually had their head shaved, and focused ultrasound still requires having your head shaved. DBS requires some of your head shaved for that. But these patients went through it, had the frame went on, we went through the procedure, but they were never treated. And some of them, as just the variability in their Parkinson's, some of them did have some benefit as well. For the patients who got benefit at 3 months, and we offered the patients who got a sham procedure, all of those patients were offered treatment, and all but one elected to do it. The vast majority of them, 30 out of 39, were still had meaningful improvement even after a year. A big difference between focused ultrasound and DBS is we have a much longer track record. For patients who have had DBS 20 years ago, many of them are still doing well. We don't have that kind of track record yet for focused ultrasound. We hope that these improvements are long lasting, but we don't know yet. And as Dr. Gilbert mentioned, this is a one and done. Retreatment is not really recommended. We have to get it right the first time. As Dr. Gilbert mentioned, in spite of the fact that it's almost doesn't make sense. How can a procedure that's making a purposeful brain injury have relatively few side effects? And that's because of the accuracy of the technology. Again, if anybody can see my mouse, there's a black arrow and a tiny little white dot. That tiny little white dot is at the target. It's got accuracy that's around 1/16 of an inch. The whole area that's being destroyed is between 1/8 of an inch and 1/4 of an inch across. So these are very small lesions. And out of the 68 people that we treated, only 3 of them had any lesion-related side effects, and none of these were severe, and they all went away after a few months. So again, if anything, these lesions are much smaller than what used to be made with old-fashioned pallidotomies. So this is kind of still a work in progress, although FDA approved. Some groups in Spain in particular, and also at UVA, have tried to approach that small target, the STN, the commonest target for DBS, with a fair amount of success, about 50% improvement. There is a risk, and that's why this is going very carefully, that one might unleash a lot of involuntary movements. So that's one of the reasons that there's not, this is not FDA approved yet. We are, as Dr. Gilbert mentioned, all the Parkinson's studies so far, and the FDA approvals have only treated one body side. That's because of that previous surgical experience, that unexpected things happened when both sides were treated. We are in the middle and close to completing the first trial at a unique target where we think that it's safe to treat both sides. And this is a early study done in Switzerland that really was the basis for the larger study that's underway in the United States mostly, but throughout the world right now. As Dr. Gilbert mentioned, and it's kind of been an interest of mine from the get-go, is whether or not this incisionless procedure could actually have fewer side effects related to brain cognition. And we're studying that right now. Preliminary data looks good in the sense that the lesions that we make are quite small and they're right at target. But as you can see from the top X-ray, deep brain stimulation probes are quite thin. They're only a couple millimeters across, but they're long. And so that cylinder that potentially is impacted, that goes through thinking parts of brain, maybe that's the reason that some patients have decline in cognition after DBS. And so that is, again, a work in progress. And part of the work that's just beginning worldwide is another aspect of focused ultrasound. Instead of trying to destroy brain tissue, to use it with lower amounts of energy and basically using microscopic bubbles that are used as contrast agents in ultrasound to vibrate them vigorously, and they actually will separate the lining cells of the brain. The lining cells in the brain are normally totally zippered shut, and that's called the blood-brain barrier. The brain is really kept in its own environment, away from the blood. And that's sadly why when someone has a brain infection that we need to do a spinal tap to access that compartment. It's a totally separate compartment. And many large therapeutics, all the fancy things you hear about, monoclonal antibodies, enzyme replacement therapy, gene therapy, all of these are too large to get through. And there's a lot of work in animals, and a good deal of it funded by the Focused Ultrasound Foundation, looking at how to get things from the bloodstream into brain. Because even in the year 2023, what we have when there are gene therapies underway in Parkinson's disease, they still require 19th century technology, which is a needle stuck into the brain and basically an injection into brain. And we hope that the selective opening of the blood-brain barrier in a particular brain region could replace a brain injection for these forms of therapy. Right now, as Dr. Gilbert mentioned, there is no therapy that can keep Parkinson's from worsening over the years, and particularly to stop some of the non-dopamine, non-motor related problems in Parkinson's, which are very disabling, including dementia. And some of that is already underway on an experimental basis. So in animals, and these experiments have been in animal models of Alzheimer's disease, by opening the blood-brain barrier with focused ultrasound, one can clear out the toxic protein amyloid from the brain. That same protein also can interfere with thinking in patients with Parkinson's disease and dementia. And there's already a group in Spain that, again, has shown that this is at least safe, and they'd love to see that it's effective to try to improve or keep cognition from worsening in Parkinson's disease patients with dementia. So they're targeting dementia, not just the motor complications of the disease. So for literally 10 years of progress, I think, again, with the support of many, many groups throughout the country and the visionary support of the Focused Ultrasound Foundation, I think the accomplishments are pretty outstanding. So we have, for Parkinson's tremor, FDA approved on one side. For one side, for dose fluctuations, already FDA approved. We have this bilateral trial that's well underway, a pivotal trial. There have been explorations on one side, the STN, and again, beginnings of experimental studies to see if we can clear amyloid out of the brain for Parkinson's dementia. And the first trial going on in Canada right now with patients trying to deliver a FDA-approved enzyme that we think is defective in many cases of Parkinson's disease, to see if we can deliver that to the brain. And so the holy grail for me for 40 years of Parkinson's research and treatment is to finally come up with something that can stop the disease from worsening, reverse symptoms, and maybe focused ultrasound will play a role in getting us there. And be happy to take any questions.
Oh my gosh, thank you, Dr. Fishman, for sharing that information. Really important. You clearly paved the way for patients to receive this treatment. So thank you, thank you. So finally, let's hear from Dr. Michael Broad about the reimbursement for this procedure. Dr. Broad joined the FUS Foundation in April of 2018 with over 20 years experience in the life sciences and 14 years of experience in healthcare-related businesses. He heads the reimbursement education program, helping treatment sites better align their internal costs to future Medicare reimbursement levels. Michael graduated with a PhD in pharmacology from Western University in London, Ontario, Canada, and has an MBA from the University of Virginia Darden Graduate School of Business. So Dr. Broad, please help us understand these reimbursement issues.
Thank you. I have the unique privilege of being able to discuss everybody's favorite topic, that is healthcare insurance. And in this case, specifically, healthcare insurance for Parkinson's tremor. So first step is determining whether or not you have coverage. And note that this is exclusively for the US. First step is contact your insurer and ask them, is this procedure covered? And it would be very helpful to know the procedure code, which is 0398T, and the descriptor should contain tremor-dominant Parkinson's disease. What you're looking for is a determination that the procedure is medically reasonable and necessary. should also determine if pre-authorization is required, and also obtain a list of inclusion criteria and limitations or exclusions. This is generally presented in the form of a medical policy document. Once you have that document, confirm with your provider that you qualify. In the absence of medical and reasonable necessity, first step for Medicare is you can get treatment in a state where the procedure is covered. So with Medicare rules, it doesn't matter where you live, it matters where the treatment site's located. If you have commercial insurance, you can make a case-by-case appeal to your insurance provider. Again, determine if pre-authorization is required. And lastly, cash pay. In this case, you'll find a lot of charge rates available out there, but note that cash pay rates are generally heavily discounted from the stated charge rate. So this is the map of Medicare coverage in the United States for tremor-dominant Parkinson's disease. In dark blue are those states where there is currently coverage, and that equates to about 30.7 million potential beneficiaries. The light blue states are those states in a Medicare administrative contractor region where there is currently a policy change under review to include tremor-dominant Parkinson's disease. And then the white states are those that are not yet covered. And I stress the term yet because I can assure you that the manufacturer has in their best interest to have as many people covered as possible. So they are most likely out there right now trying to get coverage in these states. This is a timeline of the uptake by the different Medicare administrative contractors of coverage for Parkinson's tremor. The one thing to note is that Parkinson's tremor is getting onboarded much more slowly than essential tremor. This is not cause for concern. It's explained by the fact that coverage decisions are based on the utilization rate, which is how many Medicare patients would benefit from the treatment. You can see here the blue bar is essential tremor patients. There are about 3 million essential tremor patients in the US at any given point in time. Compare that to the lower orange bar for Parkinson's tremor, and you can see that there's far fewer, about 430,000 individuals. So since the coverage decisions are made based on the number of Medicare patients that would benefit from the treatment, it's occurring much more slowly, but as I mentioned, will likely have full coverage across the US for Medicare patients at some point in the future. So in conclusion, determine your coverage, contact your insurer. Right now, coverage for this treatment is in a bit of a state of flux, so you want to make absolutely sure you're covered and confirm with your provider that you do meet the criteria. Right now, there's about 30.7 million Medicare beneficiaries covered in 25 US states. A coverage request under review would boost this to about 43.5 million beneficiaries in 38 states. And as I mentioned, the uptake of coverage for the treatment of Parkinson's disease is occurring more slowly than that of essential tremor based on the fact that there are fewer patients, but there will most likely be coverage in all US states at some point in the near future. Thank you.
Thank you. Thank you, Michael, for preparing that really informative summary. Just to clarify one thing, I know we're using some different terms during this webinar. Some people are saying HIFU, which is high intensity focused ultrasound. Some people are talking about MRGFUS, MR guided focused ultrasound, and some people just say focused ultrasound. And for the purposes of this webinar, all of that refers to the focused ultrasound ablation procedure that we're talking about for PD. So again, HIFU, MRGFUS, and focused ultrasound all refer to that same thing. So now I want you to enjoy a special part of this webinar. We're going to hear from John, a Parkinson's patient who was treated with focused ultrasound 14 months ago at Brigham and Women's Hospital by Dr. Reese Cosgrove. He will share how the technology has changed his life and provides his advice for other patients who are considering the focused ultrasound treatment. So let's hear from John.
My name is John Dutton. I'm from Martha's Vineyard, Massachusetts, and I am the father to a 14-year-old ballerina. And I suffer not only from multiple sclerosis, which I've had for 20 years, but I also have Parkinson's disease. I'm kind of a neurological unicorn in that regard. There was some bizarreness. You know, all of a sudden, my right arm was not moving properly. It was just kind of hanging there. And then next thing you know, little minimal tremors. And then like this. And so I did all the neurological testing. And it turns out I had Parkinson's disease. And it was not just any Parkinson's, it was pretty aggressive. And then we went through the drugs, you know, 1, 2, 3, 4. And the drugs were awful for me. Turned me into a zombie, and I would feel like I'm gonna pass out, and everything escalated over time. And towards the end, I was having these tremors about 95% of the time, and when you're not sleeping, it destroys the quality of your life. You can't write a check, can't put your socks on. Everything is just arduous and obnoxious and frustrating. And I was, you know, I'm not giving up hope, but I was really, is this going to be my life? My options, I believe, were down to focused ultrasound and a thing called DBS. And DBS is invasive and has wires and batteries. And it was kind of a no-brainer for me that focused ultrasound is the correct option. Doing my research on focused ultrasound, I realized how cool it was. You can use sound waves to ablate a spot in your brain that controls tremors. That's science fiction. That is so cool. There's risk, especially with multiple sclerosis. But the rewards, I think, outweigh the risks. And I said, it's time to take a shot. And I was very pleased with the doctors. They're very, they tell you everything and they're funny, great sense of humor. And I knew I was in good hands. It was the best decision I've made in my life because my quality of life went from here to here in less than 2 hours. It was amazing. First, they shave your head, and I actually look good bald, so I might have to do that again. And then they put you in the MRI machine, and they do 1, 2, 3, 4, and they kind of layer them over each other and trying to find the perfect spot. And then they go into the next phase, which is ablating that spot, heating it up. And as soon as they do that, the first time, you can tell right away that they found the right spot because you immediately go from this to this right away. And it's, the feeling of joy is like, yes. Not only did I get my tremors alleviated, but the muscle stiffness on my right side went away too. Not only that, I had some numbness in my fingers and my toes, and then it all disappeared within 2 hours. Obviously, it worked because I haven't had a tremor in 14 months, and my life has changed so amazingly. There's been one side effect. I can't seem to wipe the smile off my face. You couldn't get this smile off with a crowbar. It just feels so good. And they tell you there's a possibility of side effects. I've had a little bit of a limp, but I've done physical therapy, and that's coming around beautifully too. And I just wish everyone with Parkinson's, who's a candidate, not everybody's a candidate for this. I just wish they would use this as an option. I consider it to be a miracle. I don't toss that word around lightly, but it really is. And I just wish other people that are in my shoes could experience the joy of this. And I highly encourage it. That's all due to focused ultrasound therapy and my good buddy, Dr. Reese Cosgrove, and the fine folks at Mass General Brigham. And without getting emotional, these people saved my life. They gave me a degree of normalcy, which for anyone with Parkinson's, that's what we're looking for. Just give me some normal. Thank you.
Oh my gosh, John, thank you so much for sharing your journey before and after the treatment. I'm sure all the attendees on this webinar really appreciate your candor and most importantly are thrilled that you're feeling better. John also produced a longer 40-minute documentary about his journey with Parkinson's and focused ultrasound entitled Tremor Documentary 2022, and you can find his video on YouTube, and the link is going to be in the Q&A sidebar. So now we get to the Q&A portion of the talk, and thank you to all the attendees for submitting so many really interesting questions. So this is going to be rapid fire, panelists. So here we go. Dr. Fishman, 60 seconds or less. Can you talk about the bilateral treatments a little bit more? And can you do bilateral PD tremors, let's say, can you do ablation of the globus pallidus or subthalamic nucleus now? Like, can patients get bilateral treatments?
The bilateral treatment that was approved was for essential tremor.
Mm-hmm.
And because in the old days, the people who had the most complications were in fact Parkinson's patients. So the Parkinson's patients were specifically excluded. So right now for tremor, that particular target, only unilateral treatment is really being offered. The one trial that's going forward right now, which is almost complete, but again, the time to FDA approval, is this target that's kind of the in-between target between the STN and the GPI. So there's no availability of bilateral treatment for Parkinson's at this time.
Okay, thank you. And Dr. Gilbert, so you really clearly explained that there are patients that have some issues with medications and it can be really tricky, and some of the comparisons between DBS and focused ultrasound. So if a patient comes to you and wants to be evaluated for their PD symptoms, and they say, listen, I don't want to mess with the medications or I don't want surgery, like, can they go right to focused ultrasound? Like, how do you consult patients on that decision?
Yeah, so for the most part, a person who is looking for an advanced therapy, we do want to see whether they have a dopamine response, because at least for deep brain stimulation, and I'm not exactly sure if this is the same procedure for an evaluation for focused ultrasound, but my guess is that it is that you want to know what their best response is to dopamine, because there are a lot of, or some other neurodegenerative diseases that are similar to Parkinson's, but are not Parkinson's, which do not have a good response to dopamine, and those people will not respond well to deep brain stimulation. So one of the sort of tests that deep brain stimulation or focused ultrasound will work well is that you get a good response to medication. Now, this good response doesn't mean that you have an even response throughout the day and the ups and downs and all that, but you can, what you're looking for is that your brain can respond to dopamine and respond well at some point in the day. And if you have that, then you're more comfortable that this is regular old Parkinson's disease, and it will respond as you predict to some of these advanced therapies. So we really do want to see how a person responds to medication before we jump like sort of straight over from medication.
Okay, that is super helpful to know. Thank you. And Dr. Broad, we have some questions about their insurance reimbursement issues. And let's say they live in an area that doesn't have insurance reimbursement yet. Can they pay cash for the procedure? And how does that work? And how do patients find out about that?
Yes, you absolutely can go through the cash pay process. And as I mentioned previously, if you look at a charge master for any given institution, you're going to see astronomically high values. But note that most of the time, if not always, the cash pay rate is often 20% of the of the charge rate. And also, as I mentioned, if you are a Medicare patient and you're not in one of those states colored deep blue that I showed on the map, you can travel to one of those states to get the treatment performed as well. So really the cash pay option is only when you can't travel to that state, or if you're on private insurance, if you've appealed for a case-by-case reimbursement and been denied.
Okay, thank you. Dr. Fishman, back to you. There have been a lot of questions about the short-term and long-term side effects of the focused ultrasound procedure. You mentioned a few of the short-term side effects in one of the studies, such as dysarthria, that kind of were very short-term. Can you just better define like how long these short-term side effects last, and have there been any follow-up of these patients to know what long-term side effects are, if any?
Well, the side effects depend on brain location. So it's really because of damage to nearby brain areas. So for tremor, the commonest side effect is some degree of alteration in sensation. And these can be long lasting, but what we haven't seen in focused ultrasound, which you might be referring to, are any delayed side effects, meaning all of the side effects we're talking about, they're evident in the hours to days after the procedure. And then again, they gradually go away, as with any brain injury. What we don't see is something unexpected that appears later. So again, the other common side effect is balance. And I would say that in a few percent of patients, balance is bad enough. And I think the gentleman just alluded to it. You go to physical therapy, you work on balance, and the majority of people improve. I would say that a long-lasting serious side effect is on the order of 1 out of 100 or less than 1 out of 100 patients.
Okay, that's really helpful. And also, we mentioned before that HIFU, or high intensity focused ultrasound, is used to create that lesion. But there's also low intensity focused ultrasound, which can be used to open the blood-brain barrier, like you talked about, or even do neuromodulation. So do you have any thoughts about, one question, that can LIFU be used to kind of simulate DBS neuromodulation? Can you use it in that way?
It's possible, but very difficult to approach. Remember, a DBS is on all the time. And patients, a lot of times when a patient with Parkinson's turns off their DBS, boom, their symptoms, if it's tremor, may come back within seconds. So the issue with all forms of neuromodulation that aren't implantable is, can you a patient come into the office, get treated, and then have a long-lasting response, so they don't have to come back the next day, the day after that. And that's still quite experimental, coming up with a program. And again, LIFU is kind of similar to a lot of other forms of neuromodulation that are non-invasive, particularly magnetic stimulation that's used, and coming up with a protocol that you can treat somebody for an hour and get a response that lasts a week. That's not there yet.
Well, I think everyone, and patients and even caregivers, would appreciate that one and done, right? Just get treated once and be done.
Yep.
So we've run out of time. Sorry for anyone who has continued questions. You can submit them to the Focused Ultrasound Foundation website, busfoundation.org. This concludes the webinar. I want to really thank the panelists, Dr. Gilbert, Dr. Fishman, Dr. Broad, for sharing their expertise, and of course, John, the patient. We can see that FUS is revolutionizing how Parkinson's disease can be managed and treated. If you're so inclined, we hope you will consider helping us achieve our campaign goal with a contribution, and you can visit busfoundation.org/donate. I also want to thank the many people behind the scenes at the FUS Foundation for planning the event. If your question was not answered, if you want more information, again, visit our website at busfoundation.org. A recording of the webinar will be available on our website within the next 24 hours, so stay tuned to our newsletters and websites for invitations to future webinars and events. And again, thank you all for joining us today, and know that FUS for Parkinson's disease would not be available for patients without your generous contributions. So again, everyone, have a fantastic day.